We're going to be talking about the exemplar of hyperthyroidism. It falls under the concept of metabolism. Metabolism is in your Pearson book. You'll also find this information under your ATI book under endocrine disorders. Please pause on the screen to look at your learning objectives for this lecture. The thyroid gland produces three hormones, T3, T4, and calcitonin. Secretion of T3 and T4 is regulated by the anterior pituitary gland. So as these levels decrease, the thyroid stimulating hormone, or TSH, is released by the anterior pituitary. And this really stimulates that thyroid gland to secrete more hormones until normal levels are released and reached. This is actually called a euthyroid state. So T3 and T4 affect all body systems by regulating its overall body metabolism, energy production, and controlling tissue use of fats, proteins, and carbohydrates. Calcitonin also inhibits mobilization of calcium from bones and reduces blood calcium levels. Dietary intake of protein and iodine is necessary for the production of thyroid hormones. So, because the thyroid affects all body systems, excessive thyroid hormones exaggerate normal body functions and produces a hypermetabolic state. So the effects of hyperthyroidism and hypermetabolic effects can result in caloric and nutritional deficiencies. We'll also talk about some other multi-system effects of hyperthyroidism in just a second. Hyperthyroidism can result from a lot of different factors. Autoimmune stimulation, as in Graves' disease. We can have excess secretion of TSH by the pituitary gland. Thyroidosis, which is just inflammation of the thyroid. Neoplasms, such as toxic multinodular goiter. And if a patient is taking an excessive intake of their thyroid medications. In terms of etiology, women are actually more at risk for hyperthyroidism, 8 times more than men. And there is a genetic component to Graves' disease, although it cannot be prevented. Patients that smoke are encouraged not to smoke, because if they do, they're more likely to develop hyperthyroidism. Again, risk factors will women, and also if there's an increased iodine intake, that can actually cause hyperthyroidism, and being between the ages of 20 and 40. So in addition to the increase in caloric and nutritional deficiencies, patients have multi-system effects. In terms of neuro and sensory, they can develop hand and eye tremors, nervousness, insomnia. They can be emotionally labile, have anxiety. They might have some sensory issues like blurred vision or photophobia. Cardiovascular effects are hypertension, tachycardia. They could have palpitations. GI effects could be nausea and vomiting or some abdominal pain. Because of the nutritional deficiencies, they might have muscle wasting or loss of strength. Reproductive can be resulting in amenorrhea or decreased fertility or decreased libido, impotence for men or erectile dysfunction. These patients might have hair loss. They have a lot of perspiration and diaphoresis. They're always hyperthermic and they always feel hot. Graves' disease is the most common hyperthyroidism. It's actually an autoimmune disease defined by this toxic diffuse goiter. Manifestations of Graves' disease are hyperthyroidism manifestations, but they also have diseases of the eyes. This can include exophthalmos, which is those kind of bulging eyeballs. It's a forward protrusion of the eyeballs. If you think of Barbara Bush, former wife of the president, she actually has those bulging eyes, and she was diagnosed with Graves' disease, I believe, in the early 90s. Proptosis is that forward displacement of the eye. And again, they have a lot of other issues with their eyes. Blurry vision, diplopia or double vision, eye pain, photophobia. They might be unable to close their eyelids completely over those protruding eyeballs. So they risk kind of corneal dryness and irritation and infection. So just some things to think about. Although we may be able to treat Graves' disease, these eye symptoms are irreversible. Another cause of hyperthyroidism can result from toxic multinodular goiter. typically happens in postmenopausal women. Incidence increases with age. Manifestations of hyperthyroidism just develop slowly because they are small, independent, functioning nodules. They just secrete excess amounts of thyroid hormone. Or the patient might actually have excess thyroid stimulating hormone stimulation. This is usually overproduction of the thyroid, resulting from like a pituitary tumor, for example. Pretty rare. This is actually more common, thyroidosis. Thyroiditis, excuse me. This is inflammation of the thyroid gland, usually results of a viral infection. It is acute. However, it can become chronic if that inflammation doesn't go down within a certain amount of time, and it can actually destroy that glandular tissue, leading to hypothyroidism. A thyroid storm is a complication of hyperthyroidism. It is extremely imperative that we identify this when it's happening and provide rapid treatment because the mortality is very high. Typically, it results from a state of hyperthyroidism that is untreated, or a patient has developed some type of stressor, whether this is an infection or trauma, or maybe they even had the thyroid gland stimulated during surgery, but it can be life-threatening. It's a rapid increase in the metabolic rate caused by excessive thyroid hormone. Manifestations include severe hyperthermia, tachycardia, hypertension, GI symptoms such as nausea, vomiting, diarrhea. They can have neurosymptoms like restlessness, agitation. It could lead to seizures. Rapid treatment is essential to preserving life. So in terms of ABCs, airway, breathing, and circulation. So in terms of airway, we're going to make sure we provide oxygen and monitor for respiratory distress. Cardiovascular, they're going to have tachycardia and hypertension. So they're going to get some beta blockers to pull that heart rate and blood pressure down. We might need to start an IV with some IV fluids. Although they are tachycardic, they are also having a high temperature, so we need to be monitoring their eyes and nose and maybe need some fluid replacement. We're going to bring that temperature down by using a cooling blanket or giving acetaminophen. Tylenol. Aspirin is contraindicated because it actually releases the thyroid hormone. So just be aware of that. They're going to be on a cardiac monitor while this is happening because we're looking for dysrhythmias. And then the most important thing is we're going to have to stop that thyroid hormone from releasing thyroid. We're going to have the thyroid in itself. So we need to actually be giving something like methimazole or PTU, for example, to prevent further synthesis and release of those thyroid hormones. So the focus of care for a patient with hyperthyroidism is really preventing complications and getting them to a euthyroid state. Diagnostic tests that we look at, the most common is T3, T4, and TSH. Thyroid stimulating hormones are actually opposite, so TSH is opposite of T3 and T4. T3 and T4 will actually be increased, so TSH will be decreased. Patients with autoimmune diseases like Graves' disease, their thyroid antibody will be positive or increased. They also will look at a thyroid scan as a diagnostic test. This is a nuclear medicine scan. They shouldn't be pregnant. And nothing really important for that. It's just looking at the radioactive iodine isotope. And also it really determines how much they're going to need in terms of the oral dose, if that needs to be given. There's 3 major treatment options for hyperthyroidism: pharmacology, radioactive iodine therapy, and surgery. For pharmacology, the patient will be getting beta blockers just because of the manifestations of hypertension, and high blood pressure. They're going to need beta blockers to reduce those cardiovascular effects and the palpitations that they may have. Antithyroid medications like methimazole and PTU inhibit the production of thyroid hormones. This is actually done as an adjunct to radioactive iodine therapy, or it will actually decrease the levels of thyroid hormone before they get surgery. So a lot of these patients will get multiple treatments, such as pharmacology and radioactive iodine therapy and or surgery. So they can be getting one or all of these. Um, Antithyroid hormones are really hard on the liver, so we just want to make sure that we teach the patient to report signs and symptoms of liver failure. Um, and also, we need to monitor for leukopenia or thrombocytopenia, for example. They should not be pregnant when they're taking these medications. Iodine solutions like Lugol solution is non-radioactive. Um, but it is, the patient should not be pregnant because it can be passed on through breast milk, and so we just have to be careful if they're pregnant or not. Iodine solutions are only taken for a very short amount of time prior to surgery. Radioactive iodine therapy is taken up by the thyroid and destroys some of those hormone-producing cells. It might take multiple multiple doses for it to be sufficient. Again, contraindicated in clients who are pregnant. And it could take a long time for it to become evident, so 6 to 8 weeks. So they need to stay away from pregnant individuals, infants, small children. So think about what you learned in cancer and patients that were having internal radiation. All of those same complications and precautions you need to think about apply here, because you want to prevent radiation exposure to others. So things like don't use the same toilet, flushing the toilet multiple times, separating clothes, avoiding contamination with toothbrushes, and using disposable service items, for example. And then finally, surgery. The patient can actually have part or all of their thyroid gland removed. We would either call it a subtotal if it's a partial, or total thyroidectomy. If a total thyroidectomy is performed, the patients will need lifelong thyroid hormone replacement. The goal with a subtotal is that there's just enough a piece of that thyroid hormone remaining to supply for a thyroid hormone for normal function. So again, the patient might get some type of antithyroid hormone prior to surgery, or radioactive iodine therapy prior to surgery. The goal of those is to either stop the thyroid from producing or reducing the thyroid gland, for example. Really important things post-surgery is the patient would have their neck incision covered, so we're looking for bleeding. Because it's so close to the airway, we're looking for concerns that occur with post-op swelling that can affect breathing. The patient needs to be sitting up in a semi-Fowler's position, making sure they do all of their normal stuff that occurs with post-op, so airway, breathing, and circulation. But respiratory distress is huge just because of the location and where it's at. The patient may have difficulty speaking afterwards because the laryngeal nerve damage is so close. But the most important thing to watch for post-op thyroidectomy is for hypocalcemia. This can result from the parathyroid damage that occurs intraoperatively. So signs of hypocalcemia is Chbosky's and Trousseau's signs. Make sure that you have the ability to give the patient IV calcium gluconate or calcium chloride as needed. And then long term, the patient, especially with a total thyroidectomy, needs to be taught about lifelong thyroid replacement, because they will then have patients or have the diagnosis of hypothyroidism. Okay. So our focus in this class is adult, but I just want you to realize that newborns and children can develop hyperthyroidism. I just want you to look at these manifestations here. For a child with hyperthyroidism, looks a lot like something else, right? Maybe ADD or ADHD, just something to think about. Pregnant women can actually develop hyperemesis gravidarum, hyperthyroidism because of that. And then if it's uncontrolled, it can lead to death of the infant or stillbirth. So just some things to think about. Our focus is older adults. These patients are actually treated more with medications than surgery, when we have to be very cautious about treatment because there's a lot of controversy about the normal levels of TSH in older adults. So they're treated much more conservatively.